Welcome back, everyone. We've got a fantastic explainer for you today, unpacking a truly fascinating and, honestly, often misunderstood medical puzzle. We're jumping right into a high-yield breakdown of systemic sclerosis based on the brilliant modern rheumatology framework from Dr. Vishwa Prakash Tiwari at Rheumatology. We're going to visualize the deep, microscopic pathogenesis of this condition. It's not just about memorizing facts, it's about really grasping the mechanics of how this disease takes hold at a molecular level. If you're ready to master this, let's get right into it. First up, we've got to shatter a really stubborn, outdated misconception. For the longest time, systemic sclerosis, or SSC, was thought of as just a disease of skin thickening, just fibrosis. But that's absolutely not the whole story. SSC is actually a highly complex, immune-mediated fibrotic vasculopathy. That word right there, vasculopathy, is the absolute key. The modern understanding is that this is a vascular-first disease. It all starts deep within the blood vessels. Here's the roadmap for our explainer today. We're going to cover 1. The core triad, 2. Endothelial injury, 3. The endo-MT bridge, 4. Immune activation, 5. Autonomous fibrosis, and finally, 6. Therapeutic targets. So let's dive into part 1, the core triad, which acts as a self-amplifying loop. Think of this disease as 3 massive, interlinked gears spinning together in a relentless cycle. It all kicks off when genetic susceptibility meets an environmental trigger, maybe a virus, silica, or oxidative stress. That spark causes step 1, endothelial injury in the microvessels. This microscopic damage inevitably triggers step 2, immune activation. Those inflammatory pathways then fire up step 3, fibroblast activation, and that finally leads to heavy extracellular matrix deposition and vascular remodeling. But here's the catch. It doesn't stop. The remodeling causes more ischemia, which causes more inflammation, looping right back around. It's an irreversible cycle of persistent fibrosis. Moving on to section 2, vasculopathy and endothelial injury. This is the initiating spark. Okay, so the very first thing that goes wrong at the microscopic level, the endothelial cells lining the blood vessels actually start dying off. Apoptosis. When they get damaged, they create this critical, localized molecular imbalance. They start releasing way too many powerful vasoconstrictors, like endothelin-1 and angiotensin-2, while sharply dropping the production of vasodilators like nitric oxide and prostacyclin. This severe imbalance clamps the vessels down in persistent vasospasm. Clinically, you'll see this as the Raynaud's phenomenon, where fingers turn strikingly white, then blue, then red because they are literally starved of blood flow. Now here's a massive paradox for you. Think about it. If your tissues are starving for oxygen because of damaged vasculature, your body should naturally pump out VEGF, vascular endothelial growth factor, to build new blood vessels, right? And it actually does. VEGF levels are totally elevated in SSC. So why does angiogenesis fail anyway? Why don't the vessels just regenerate? Well, the answer is pretty wild. The whole vascular repair system is fundamentally broken. The body starts producing abnormal, anti-angiogenic versions of VEGF. On top of that, the stem cells meant to build new vessels, the endothelial progenitor cells, are completely dysfunctional. You've got abnormal signals from parasites and chronic oxidative stress just constantly sabotaging the repair process. The end result? Catastrophic capillary dropout. The microvessels literally just vanish, leaving avascular, oxygen-starved tissue behind. That brings us to section 3, endo-MT, the literal bridge to fibrosis. You guys, this is a huge conceptual leap in modern rheumatology. Endo-MT stands for endothelial to mesenchymal transition. Driven by powerful pathways like TGF-beta and Wnt, these injured blood vessel cells don't just die. Some of them literally shapeshift. They lose their normal vascular identity, dropping markers like CD31 and VE coherin, and they gain alpha SMA, transforming into myofibroblasts-like cells. It's the critical point of no return. Injured blood vessel cells turn into aggressive, collagen-depositing factories. This perfectly explains why systemic sclerosis is a true fibrotic vasculopathy. Let's look at section 4, immune activation, cytokines and autoantibodies. So the adaptive immune system, specifically B cells and autoantibodies, they are definitely not just innocent bystanders here. Modern science views B cells as active modulators of this fibrosis. Specific autoantibodies cleanly map out distinct clinical trajectories for the patient. For example, anticentromere points straight toward limited SSC and pulmonary arterial hypertension. Anti-scleral 70 That's a red flag for diffuse SSC and severe interstitial lung disease. And anti-RNA polymerase III strongly indicates aggressive diffuse skin disease and the dreaded scleroderma renal crisis. These aren't just labels, some of these actually directly promote the vasculopathy. And man, the innate immune system is just throwing gasoline on the fire. You've got plasmacytoid dendritic cells releasing a chronic flood of type I interferons. Macrophages switch into this M2-like phenotype, pumping out the master pro-fibrotic cytokine, TGF-beta. Plus, T cells lean heavily into Th2 and Th17 polarizations, releasing interleukins 4, 13, and 17. All of these potent cytokine pathways converge on one terrifying goal: directly stimulating unstoppable, aggressive collagen synthesis.
Which leads us to Section 5, autonomous fibrosis. We're looking at mechanotransduction and organ damage.
All right, so early on, fibroblasts need chemical signals like TGF-beta from immune cells to make collagen. But eventually, a physical, mechanical feedback loop takes over. The accumulating extracellular matrix gets incredibly stiff. This sheer physical stiffness activates integrins and YAP/TAZ pathways right on the cell surface. The rigidity of the tissue literally acts as an instruction manual for the fibroblasts, telling them to lay down even more scar tissue. At this point, the fibrosis is fixed. It doesn't even need an external immune trigger anymore. It is completely self-sustaining. When we zoom out from these microscopic pathways to the whole patient, this usually manifests as one of two life-altering clinical phenotypes. You have limited SSC, featuring slower fibrosis mostly on the distal skin, like the hands and face, but carrying a high risk of vascular issues like pulmonary arterial hypertension. Then you have diffuse SSC, which is way more aggressive. The skin thickening spreads proximally to the trunk with a much higher rate of fibrotic internal organ involvement, especially devastating the lungs. Because this attacks the blood vessels and connective tissue systemically, it ravages multiple vital organs. The lungs suffer from interstitial fibrosis and hypertension. The kidneys develop these ischemic onion skin lesions, leading to severe renal crisis. The heart undergoes patchy myocardial fibrosis, triggering arrhythmias. And the GI tract, it faces severe dysmotility because the smooth muscle in the esophagus is physically replaced by rigid fibrosis. The multi-organ devastation is really intense.
Finally, Section 6, therapeutic targets. How do we translate all this pathogenesis into actual treatment?
This is the exciting part. We can actually intercept these exact pathways we've been discussing. If endothelin-1 is clamping down vessels and causing fibrosis, we hit it with bosentan. Is IL-6 driving immune inflammation? We use tocilizumab. We can target the autonomous fibrosis directly with nintedanib, block the aggressive B cells with rituximab, and force the vessels open with PDE5 inhibitors. By perfectly mapping out the pathology, we map out the interventions. To tie this whole explainer together, I want to leave you with this perfect summary quote from the source material. Systemic sclerosis is a genetically primed, immune-mediated fibrotic vasculopathy in which endothelial injury initiates defective vascular repair, resulting in progressive multi-organ fibrosis. That single sentence really says it all, perfectly encapsulating the modern disease model, from the vascular spark right down to the fibrotic fire. But I do want to leave you with one big, provocative question. We can target the immune system, and we can force blood vessels to dilate. But the absolute holy grail of SSC research right now is this. What future therapies might finally break that rigid, autonomous mechanotransduction loop after the tissue is already stiffened? It is a massive puzzle, and the brightest minds in rheumatology are chasing it right now. Thanks so much for joining me for this explainer. Keep questioning and keep learning.